Hey everybody, been back with this week's case study on abdominal injuries. As a reminder, log into or go to masteryourmedics.com to start your free 3-day trial. Okay, so the preview of this week's case study revolved around you responding to a call for a 26-year-old male experiencing abdominal pain. As you arrive, this is what you see. A young, what appears to be a very physically fit male laying on the gym floor at a local CrossFit gym. He's laying next to a heavily loaded barbell and is complaining about a sudden onset and stabbing pain in his left upper quadrant. These are the vitals as shown with a preview of the monitor. Heart rate of 113, sinus tach. He's 96% on room air, has a GCS of 4, 5, and 6. His airway's patent, breathing regularly at a rate of 22, an end-tidal of 35. His skin is cool, pink, and clammy. His eyes are pearl, and his blood glucose is 98 or 5.4. As you can see, also looking at the monitor, you'll notice the pleth of that. Not quite the kind of pleth that we're looking for. Just so with that, has a blood pressure of 104/70. So into the secondary assessment, we found just a sharp pain in the left upper quadrant, and he's having some guarding. He has no allergies, no past medical history, and on no medications. For breakfast, he ate egg whites and some oatmeal, and states that kind of the events leading up to this, he was feeling achy and having a pretty significant sore throat, but he just attributed it to the heavy and intense training he's been doing for an upcoming fitness competition. That pain was sudden just in the middle of doing a very heavy deadlift, left upper quadrant, and also says he has a really odd pain into his left shoulder now that's acute. The pain constantly hurts, it's tender on palpation, and he rates it an 8 out of 10, comparing it to when he tore his ACL. His abdomen, soft everywhere else, just tender in that upper quadrant, non-distended. Circulation, motor, and sensory are equal times 4 in all extremities. His lungs are clear and equal bilaterally. Heart tones are normal, and there's no respiratory compromise. So the questions proposed was, what is your differential diagnosis? What are the type of assessments would you want to do? And once you develop and formulate your differential diagnosis, what's going to be your treatment plan? So let's get into it. So first, let's talk about location, location, location. Everything in the abdomen, it's very important that we understand the anatomy and location and kind of physiology also of what's going on in the abdomen and with those respective organs. So you can see our scenario targets the left upper quadrant. So in there, we're going to have part of the liver, in the stomach, and over here in the spleen, and a lot of the large and small intestines. Okay, so one thing to know about abdominal organs is the solid organs. Solid organs are protected inevitably by our pre-designed roll cage. So you can see those solid organs of, your liver, spleen, everything is protected by the rib cage. So those ribs protect those solid organs just by design. So what's notorious about those solid organs is they bleed, because the liver and the spleen, full blood, so they bleed heavily. They also will have somatic pain, and that somatic pain that relates to like muscles, bones, and solid organs due to all the nerve endings that are going through that solid tissue. So generally with those solid organs, it is pinpoint pain. Just like if you've hurt your thigh or your ankle, you can pinpoint exactly where it's at. In comparison to hollow organs, they're a lot less protection. The abdominal wall is really the only thing that's protecting those organs. They can still bleed, as every organ, everything in our body does contain blood, but not nearly as much as a solid organ. Notoriously with them though, they will spill their contents into that abdominal wall or into the abdominal cavity, causing peritonitis. So just that irritation, inflammations of that peritoneal wall lining, causing that diffuse or more visceral pain, just like you get a bellyache and it just kind of hurts everywhere, more of a visceral pain. Okay, so left upper quadrant, what could be relating to that? So events leading up to this, just still trying to formulate that good differential diagnosis. Going into this before, the young athletes complaining of aches, a very sore throat, general fatigue, has been experiencing some maybe possible overexertion from intense workouts, and maybe some muscular strain from all the intense and the heavy weights that he's been training with. So, as some of the comments on Facebook and everything alluded to, a lot of people started talking around infectious mononucleus. Okay, so mono is that kissing disease that's most generally spread by human saliva, hence the kissing disease. It is caused by the Epstein-Barr virus. So 1/4 of young adults that have the Epstein-Barr virus will develop infectious mono. And then the issue with that spleen is what we refer to as splenomegaly. So spleno, what did you say? Splenomegaly, that is that enlarged spleen. So you can see by the illustration here, a very zoomed in picture of what the normal size of that spleen should be. But when you have that enlarged spleen, you can see how much of a space that it's taken up. So the ribs are keeping it well secured in, then it gets down below the ribs, and that large organ starts to become unprotected by that rib cage. So the diaphragm becomes closer to it. It's closer in just to our flank side, sticking out down into our very lower of that left upper quadrant. So the spleen, understanding what it does. The spleen, it stores blood. It's also filtering of the blood by the old blood cells and everything coming in. You know, blood cells have their own life cycle, so as old, worn out blood cells come in, the spleen basically filters those out, recycles them, and helps make new blood cells, producing red blood cells and white blood cells. So those white blood cells, whenever white blood cells are always elevated anytime we are susceptible to some type of infection, something going on, such as infectious mono. So with infectious mono, a lot more white blood cells being stored and developed in that spleen. Now, with splenic ruptures, that's always something that's notorious for mono, from that spleen being ruptured, okay, because it's enlarged. Any type of strain, physical activity, contact makes that spleen very susceptible. It's becoming very, very stretched out and a lot more fragile. As I said, going out below that rib cage and really open itself up to possible damage. So we've got multiple levels of, or multiple grades of how a spleen can rupture. Basically, a grade 1 spleen, just a very small laceration. Grade 2, grade 3, and grade 4, pretty much just going up to the extent of how big that laceration could be. Up through a grade 5 meaning a basically a complete annihilation of the spleen, from significant trauma, skin spleen, to complete rupturing of the spleen. Whereas a grade 1 through 4 is more of um, a laceration. Getting into grade 4 could be a complete separation of a devascularization, very deep cut, chopping that spleen in half, where a grade 5 is just like that water balloon rupturing, just completely mangled. So going back to the presentation, as a reminder, the vital signs of this patient. Okay, so we came up with our differential diagnosis of a splenic rupture based on a presentation of susceptible of infectious mono, the physical strain, overexertion by that, engaging all those core muscles, abdominal wall, overexerting, just a lot of strain on the body, causing that spleen to just start to tear. Okay, so we came up with our differential diagnosis of that splenic rupture, and they also have the shoulder pain. Well, why is that? So that is called Kerr's sign. So that Kerr's sign is from that diaphragm being irritated and it going through that phrenic nerve. That phrenic nerve can also relate back into near the top of the clavicle. So as that excuse me, as soon as that phrenic nerve becomes irritated from that enlarged spleen rubbing on it, it makes you feel that nerve pathway next to the clavicle. Okay, so with the vital signs, Patient in shock, yes. Compensated or decompensated. We can see we've become kind of tachycardic. We've got a borderline low blood pressure, got poor pleth on there, a lower end tidal. So yes, this patient is in compensated shock and partially compensated. So they're at the point where they're gonna be uh, becoming hypotensive probably before too long. Their skin, remember, was cool, clammy. So the largest organ in the skin, I'm sorry, the largest organ of the body, the skin, is starting to hypoperfuse. So that clamminess coming out, the patient is in shock, most definitely. Okay, so I know in a lot of education programs, they talk about, blood in the abdomen, then it becomes distended, and you'll see this bruising on the side called Gray Turner, or bruising around the umbilicus area called Collins sign. But those are not acute findings. Most generally, those signs and symptoms that you see of bruising in the flank or distended abdomen, that's 24 hours at least after the injury. So as an adult, depending on our anatomy and our size, somewhere around 5 liters of blood, depending on your size, some less, some more, could be filled up into the abdominal cavity. If we're holding 6 to 8 liters of blood total in our body, the abdomen can store a bunch. So trying to find that distended abdomen or looking for bruising around there is going to be a later sign of an injury. Maybe if this athlete would have called, you know, 2, 3, 4 days later and you show up and you start to have some bruising around their flank, that's when you're going to start to see that. So if this went untreated, that bruising in there, maybe starting to distended or a little bit more of a rigid abdomen in these areas is going to be those signs of not acute, but more of a lengthy onset. So treatment, what are we going to go with here? So we determined that our patient is in compensated shock, and our big fear of people going to shock is hyperperfusing of end organs, most notably the brain. The brain is the most sensitive organ to blood flow, so that's number one. End organs such as kidneys, liver, and those things, they can go much longer without having blood before extensive damage in necrotic tissues and whatnot. Okay, so when we're dealing with abdominal bleeding intra-abdominally, hard part is us that we can't control that bleeding. If we had an open wound on the arm, direct pressure, tourniquets, whatnot, we can prevent more blood pulling out. But inside, we can't do anything, especially if the abdomen is still closed. So in this, a lot of research goes into these different things. You've probably heard of the phrase of permissive hypotension, whereas before we think that hypotension is a very bad thing, but which it is. But allowing that patient to stay hypotensive can increase their risk of survival. So a lot of research develops around some basic concepts. Maintaining a lower MAP with intra-abdominal injuries and believed internal hemorrhaging, a lower MAP, lower mortality rates. So letting that MAP stay a little bit low, not necessarily worrying about it too much, improves survival rates. Increasing that MAP to a normal range around that 65, or getting a systolic pressure around 100, 110, increase mortality rates. So trying to fix their perfusion has a high increase, exponential increase of killing these patients. So some clinical evidence. So there's one study based on rats where, ironically, rats have the same type of MAP that we do, of letting those lab rats maintain a MAP of 50 to 60 drastically improve their survival rates of experiencing intra-abdominal hemorrhaging. Now that's acutely, not letting them maintain at a 50 or 60 without intervening any type of surgery or opening up the rats trying to control bleeding. So we're talking on that up to 1 hour point. After about that 1 hour, which going back to a lot of trauma things, we've heard of the golden hour, which is more commonly referred to now as that golden period. Okay, so within that 1 hour of not treating, not fixing, no intervention, things kind of start to dwindle down. Okay, there was also a lot of studies talking about giving intravenous fluids, where there was even some retroactive studies that showed that even patients who just got an IV without any fluids, they were saying that, well, starting an IV made things worse. But then a lot of those studies have been thrown out because of just a lot of skewed evidence. But the most evidence shows that increased mortality rates to patients who are trying to get crystalloid infusions in a pre-hospital setting. So this is not blood, this is just crystalloid infusions, give normal saline, LR, something like that in a pre-hospital setting, of trying to give a large fluid bolus because their blood pressure is going down, is killing them. So think about all of the organs in the abdominal cavity. You've got all these really small vessels going through. So in the liver, spleen, stomach, lots and lots of vessels. So if they start to tear, and like in this splenic rupture scenario, you start giving a large amount of fluid, it just keeps everything pushing out. Whereas the natural tendency of blood vessels is to constrict when they're damaged. If you continue to overpressurize them, it's going to not allow them to constrict to slow their own bleeding, and you're just opening up and causing more pressure to that tissue and could actually make that tear just a little bit bigger. But you're not allowing the body to just naturally cause vasoconstriction to shunt blood away. Because we know that gastric motility is one of those side effects to patients being in shock from a sympathetic response because blood gets shunted away from these organs due to vasoconstriction. So if we start giving them large fluid boluses, 2 large bore IVs, dump the fluid in them is what historically a lot of places were taught. But if you do that in these, you're going to make things significantly worse by not allowing vasoconstriction to happen, increasing the tension and the pressure on that soft, brittle abdominal cavities and organs that are already being damaged. Some other considerations with that is TXA. So TXA is just that great drug that's got a significant amount of research backing it to use it in hemorrhagic shock. Okay, so in this, a lot of the studies, no studies that I have seen have any type of discrimination against organs, where if it's a believed liver versus spleen versus any other type of internal hemorrhaging, does it say to contraindicate TXA? And between different organs, there was nothing saying that splenic ruptures benefited best from TXA as compared to hepatic injuries or whatnot. Just TXA works great equally across the board for internal hemorrhaging. Okay, but in this, the patient is borderline compensating. So what you have to think about is here is you have to mix TSA in a volume of fluid. So you have to be given that over 1 gram over 10 minutes. So if you start that fluid bolus, you're still having to give it 100 mLs, which in grand scheme of things is not a lot if you're giving it to them over 10 minutes. It's 10 mLs a minute. But if you're thinking about giving these boluses or mixing it in or whatever your protocol set up, think about if you really need to give that TXA or if they're compensating as they can, or if that bolus is going to be bad. But most things, TXA early in the internal hemorrhaging, if you suspect it, we can't control it, give them TXA, give them to some place that can do surgical interventions. Okay, so ultimately, our treatment is going to focus around keeping the brain perfused. It is the most sensitive thing. And of course, I had to put in the Play-Doh brain just because we all know how much Jeff likes Play-Doh. So of course, we got the Play-Doh brain in there. So keep that brain perfused. A lot of research just kind of bases around perfuse the brain, try to maintain a radial pulse. Again, a lot of places were told a radial pulse equates to systolic pressure around 70 or 80. That's different. There's not a whole lot of research that supports that it's definitely 80, definitely 70. Just kind of a good consensus, high probability around that. So perfuse the brain, it's the most sensitive thing. Don't let them go to the hospital brain dead. Prevent heat loss, the most basic thing we can do to shock patients. Prevent that heat loss, let natural coagulation happen. If the body is really cold and starts hypothermia engagement, they become more acidotic. It disrupts the complete coagulation process. So keep them warm, layer them in blankets. Don't let them go further into shock. And then ultimately get them to surgery where they can get bright lights and cold steel. Trauma is a surgical disease, so they need to get in to have surgery done on this. So with the splenic rupture, if it's one of the lower grades, they may be able to go in and just provide simple sutures, open them up, even just small sutures for the small incisions, or they may have to do a complete splenectomy, meaning they've removed the spleen completely. Because remember, we can survive without a spleen. It just kind of disrupts some different things of um, immune processes, since the spleen is part of the lymphatic system. Okay, so keep the brain alive, keep them warm, get them to surgery, nothing too aggressive. So we can maintain that permissive hypotension to let that blood pressure stay a little bit lower. We're not trying to give them boluses so we don't end up causing more harm than we do good. Because remember, as it said before, lower MAPs increase survival. Okay. We put them up to a normal MAP or normotensive, as we say, that's going to increase mortality from that extra fluid, causing more peritonitis, dumping more things in the abdominal cavity, flushing things out, and going from there. Okay, well, hopefully everybody got some stuff out of this, knowing that permissive hypotension is susceptible in is acceptable in intra-abdominal hemorrhaging. That mono has not a high correlation with splenic ruptures. I think the research showed it was on about 1 to 2% of patients who had mono would develop a splenic rupture. But that's why, hopefully it's because that everybody's following the doctor's orders. They've been diagnosed with mono and they say, hey, you need to go on rest. No high impact, no overexertion, just simple stuff so you don't blow up your spleen. Okay, well, it's Ben signing out. I'll see you guys next time.